let's move over towards, prevention and treatment, because I mean, that's where the rubber hits the road here is, it's scary enough to hear about all this, but fortunately there have been some advances. And fortunately, as the bugs are getting smarter, hopefully we are too. And we're starting to learn what interventions might be appropriate both for prevention and for treatment. So maybe let's just talk about that for a minute. If you want to shed a little light on kind of is the right approach to prevent them rather than treat them. I mean, that seems to be the paradigm in healthcare. Can these be prevented, or is it they're inevitable and we need to treat them once we get them?
Prevention is always the best cure, of course. Preventing these microbes attaching is by far the better approach, because once they start growing, proliferating, it becomes more challenging to get rid of these biofilms, because they're very recalcitrant when they form within a biofilm. So preventing them should be of paramount importance. And of course, in any sort of surgery, following the correct aseptic guidelines, of course, to prevent cross-contamination, to prevent ingressing of microbes, because a lot of them are either exogenous from outside or endogenous from the patient themselves. So a lot will come from like hair follicles, so you get a lot of staph forming there. So when incisions are made, the likelihood of getting one bacteria in there can be potentially quite high. And as we know, a lot of bacteria can multiply every 20 minutes. So you imagine during surgery of how many bugs may be multiplying. So the first point of call is, particularly in an acute situation, is prevention. So we can prevent the formation and adhesion of bacteria, because what happens is any bacteria is a bit like your oral cavity. We get a lot of transient bacteria that will go into areas of the body where they're in this not so sure sort of scenario. They sense the environment, and bacteria have things known as touch receptors. So ultimately they can sense a surface, and these can switch on genes. So if you can prevent or make that environment hostile to the bacteria to begin with, it's less likely they will then attach because they don't want to be there. So we can have things.
Yeah, so we've always talked in surgery about, infection is a probability issue. And what we want to do is reduce the burden of bacteria within a wound. And that's why we go through all these steps of, making sure we've got a host that's healthy, making sure we scrub, making sure we have a clean room, making sure that, we drape appropriately, making sure we change our instruments appropriately. But I always tell my residents and fellows, and when we talk about this, that sterility is not guaranteed, and so it's a probability issue. And there's as you mentioned, there's usually some bacteria that slip through, whether it's through the follicles or through the dust in the air or whatnot. And so talk to us about what we ought to be doing, to prevent, if we've done everything we can do, and we've made a very sterile field, but we know would you agree, we know there's got to be some microorganisms still threatening us in almost any clean surgery. So we've got to, you talk about making the environment less hospitable for them, more hostile to the bacteria. What does that look like? What should we be doing?
There's many different scenarios, but ultimately, back in the good old days, it's always good to irrigate a wound, keep fluid in there. But what we're starting to learn, particularly in medicine, which we've taken from different industries like the food industry, a lot of industries like that use things like detergents, surfactants. These are technologies that affect how well a bacteria or microorganism can attach onto the surface.
Yeah, I want to highlight that, because I think that's a really important issue. I was always taught we had this little rhyme, right? The solution to pollution is dilution. And so as surgeons, we were always taught just pour in a bunch of the solution, normal saline. It's a mechanical issue, and it's a dilution issue. But what you're suggesting, and I think this is a really important point to highlight, is that what you irrigate with may be as important as how much you irrigate.
Correct. The irrigation is very important, and also it is contact time. A lot of people don't realize it's a bit like using a disinfectant, isn't it? With the COVID-19 around, of course, there has to be a certain contact time that you're leaving a technology on a surface to kill a virus or prevent it forming on a surface. And it's the same in the medical profession. If we're going to use an irrigating solution, ultimately a lot of people use tap water, they'll use saline, but this has to be used at a certain PSI, of course, to make a mechanical flushing effect. But what you're finding now is that if you're using things like antiseptics, provided these are used appropriately and they're left within a wound environment for a certain period of time, what these help to do is if there is any contamination of that wound, that would make the environment very hostile to the bacteria, but at the same time, any potential residual antiseptic that's in there, provided it's been in there long enough, will start altering that bacteria and start making it often more susceptible to be killed by white blood cells. But we've got to also add things like surfactants. Surfactants are very important.
Yes, but so tell us about, what is a surfactant? Give us kind of a definition of a surfactant. Is it a soap? Is it something more than a soap? We've heard that term now. We hear it in, the lung. We hear it in other areas. Give us a definition of a surfactant and tell us, why is that so important?
Well, surfactants are called surface active agents. Essentially, they change the surface tension, and what that means is, and I won't go into too much detail on this, that if you change the tension between two surfaces, it allows things to mix together. It's a bit like adding your washing up liquid when you're washing up. It helps to disperse, to break things up. And ultimately, surfactants, there's many different sorts of surfactants, and it is a multi-billion dollar, multi-pound industry. So we've got to take the concept of surfactants from natural surfactants. In the human body, we have things known as biosurfactants. Bacteria use surfactants to stop other bacteria growing on a surface. So, for example, you have Pseudomonas aeruginosa. It doesn't like Staphylococcus aureus a lot, another bacteria. And what it does, it produces a thing known as a rhamnolipid. Now, that's a biosurfactant. And what it does, it releases it and it changes the surface tension and prevents other bacteria attaching. So it becomes a bit slippy, a bit slimy. I won't go into too much detail, though. So, again, it becomes awkward for the bacteria to attach onto that surface. But we know surfactants are very good, as I said, at dispersing things. So often in the food industry, you'd add detergents and surfactants to break up the biofilm, to break up the aggregated bacteria, and then you'd supply your antimicrobial then to kill the bugs. But surfactants can also as well help to potentiate bacteria. And what I mean by that, they can start altering the cell wall of bacteria to allow antimicrobials to be more efficacious. So they boost the performance of antimicrobials.
So are they making the cell wall more permeable?
Yeah. So you can lower the levels of antimicrobial and get the same efficacy as you would with your higher levels of antimicrobial by combining a surfactant with an antimicrobial at higher concentration. So they bring in all these combinations of positivity in terms of killing bugs, dispersing bugs, breaking up biofilm, and then preventing reattachment. Because a lot of people forget you're trying to prevent attachment, but if it does occur and you can remove that biofilm and bacteria, you want to try and then prevent them from reattaching. You imagine what you do to your teeth. You're brushing them all the time, and toothpaste contains a lot of surfactants. Some contain a lot of antiseptics. And imagine what you're doing to disrupt that biofilm, then trying to have something on your teeth that prevents them regrowing quickly. And it's the same in a wound scenario. If you can add agents in there that prevents them reattaching, you can reduce the incidence of infections.
So let's take this now to, real world practical level. I'm a joint replacement surgeon. I've just put a knee replacement in, and there's a big foreign surface that I would suspect is ripe, very attractive to the bacterium. And we're washing it with saline and we're scrubbing it and we're hoping to close the wound before we, run into trouble. But what you're suggesting is that there may be, and I don't want to put words in your mouth, but there may be a role for a surfactant at that point to help ensure that that surface is cleared of any microbials that might be tempted to adhere to it.
Yes, because a lot of surfactants, as well as changing the environment to reduce adhesion, some have also been shown to help potentially reinvigorate any cells that have been altered or affected, and they may be undergoing necrosis. So there's things like peloxamers, there's work going on those, looking at those reinvigorating human cells. So they have another role to play, and a lot of very non-cytotoxic, because we can have cationic surfactants, anionic surfactants, neutral surfactants. They all have a role to play. But again, it's if you're combining these with things, you have to show a synergistic effect or an additive effect of adding these. But surfactants per se, there's a lot of solid evidence out there that they have a significant role to play in altering environments, preventing bugs attaching, dispersing biofilms.
So I want to get back to the combination then. So you've told me that surfactants are important. I mean, I remember when I was training, there were proponents of Castile soap. There would be arguments about just use soap, or others who said just use an antimicrobial. I think what I hear you saying is that they ought to be used in combination. That it may not be sufficient to simply use a surfactant. It may not be sufficient to simply use an antimicrobial. That if you want to get the most efficacy and give yourself the best shot of preventing biofilm formation, that these two agents are probably best used together.
Yeah, provided there's an added benefit. In an ideal world, what you're trying to do, if I take a surface, and it could be an inert surface in your kitchen, in a manufacturing line, you want to add your surfactant or detergent first to remove or disperse the biological matter. And the reason you're doing that is because you're going to then add an antimicrobial. But unfortunately, the more biological matter you have, the less efficacious your antimicrobial will be, because there's a demand, a biological demand for that antimicrobial, so there'll be less available to kill the bugs. However, you've got to think of practicalities of this in a medical sort of scenario. It's often not practical to keep adding different solutions and leaving them for 10 minutes, so combining them is a good approach. But if you move into dentistry, you imagine what they do in dentistry when they're irrigating a tooth. They'll add an irrigating solution, they'll add things like EDTA because it chelates calcium. Then they'll do another wash, they may then use a chlorhexidine, then they'll do 4 or 5 different washes, because all those different washing techniques have a role to play. But of course, in dentistry, that's a bit different to orthopedic surgery, of course.
You're saying we may be a little more impatient than the dentist. I get it.
So combining them, as long as you can show there's an added benefit of doing that, if there's a synergy, so you're adding the surfactant to boost, for example, the performance of the antimicrobial, or the antimicrobial, as we know, some can be quite cytotoxic. So it could be that the surfactant's in there to support or suppress the cytotoxic effects of an antimicrobial. But if you've got an antimicrobial that has low cytotoxicity, combining them with a surfactant, again, could reduce that cytotoxic effect even further. So it's this benefit of adding them together.
Yeah, so I think you're touching on an area that I think is near and dear to most surgeons' hearts, which is ensuring that whatever you're using is safe, that it's not going to do damage to the host tissue. And we all know that keeping the host healthy and the host tissue healthy. So I don't know if you have any specific antimicrobials in mind, or, we see people wanting to use povidone iodine. You mentioned chlorhexidine in the dental world. Um, there, how should we as surgeons start to think about the relative safety and lack of cytotoxicity of available antimicrobials and compared to their uh, effectiveness in reducing the bacterial concentration?
It's all about balance. It's one of these terminologies, homeostasis in the body. You don't want things to go out of sync, of course. So it's this cost-benefit approach. You've got to bear in mind when medical devices are going through a design and development process, we do a thing known as ISO 10993, which is a biocompatibility test, and generally consists of various different tests from sensitization, irritation to cytotoxicity. The basis of the cytotoxic test is you leave the antimicrobial in contact with cells for 24 hours. So if you use an irrigating solution with an antimicrobial, generally you'll only use that irrigating solution for 5-10 minutes, probably no longer than that generally, but generally you'll find those cytotoxic effects are suppressed slightly based on what you would normally do to get the medical device cleared for a 510K or a CE mark. So what you're finding is that a lot of these surfactant and irrigated solutions get diluted, particularly if there's tissue fluid exudate in there. So what you're finding is, as you disperse that irrigating solution, the cytotoxic effect does decrease. And a lot of these antiseptics, so your PHMBs, your biguanides, for example, your benzalkonium chlorides, at low concentrations, even though at higher concentrations you class them as antiseptics, at lower levels, they are surfactants. So they have this combined effect as well, which can be beneficial.
Interesting. And so is there a best method for delivering them? I want to just touch on that because surgeons have been debating this, whether to use, high pressure delivery versus, bulb syringe. Do you have any take on that in terms of best method of delivery? And then the other question I have for you, as long as you're responding to that, is do these all need to be washed out? Like, can we leave these in at the end of the case, or is it important because of some sort of concern that they need to be cleared from the wound?
I think when of course, we've got to supply a certain PSI. The reason you're supplying a certain pressure of the irrigating solution is to wash things out. So ultimately, the quicker you can do that, again, the quicker you can wash out the bacteria, because you don't want the microbial bioburden to increase. So whatever method is going to dependent on the surgeon, of course, and what their preferred method is. But I think there has to be a certain pressure. It would be different if you're in a chronic wound situation, because if a biofilm is already formed, biofilms are very viscoelastic. So they're a bit like an elastic band. You may apply a pressure and that biofilm will extend itself, but when you remove that pressure, it recoils. And that happens in a lot of water pipes. So that scenario is different. But in an acute wound scenario, if you just opened up the wound, an irrigating solution at a certain pressure, and by whatever method you apply, that would help getting some movement of bacteria out of that wound environment and make it very hospitable.
Some of that is dealer's choice, just surgeon preference, but there needs to be some sort of pressure just to have that effect, and there's a certain efficiency factor. What about clearing it from the incision? A lot of surgeons who use different agents want to then wash it all out with saline again. Is that advised?
Well, we've got the scenario again. It's past biocompatibility. If it's been approved as a medical device, it must be safe for use. And what you're finding is it will get diluted very quickly anyhow with the wound exudate. So again, that comes down to clinician, and it comes down to the antimicrobial as well. Bear in mind that you have many different types. You have your very fast acting ones. So your iodines, your chlorhexidines, of course, use the skin preps. The reason they're used is they're very fast acting. So they're going to be generally a bit more cytotoxic than a lot of the other antimicrobials that are a bit slow in their performance. So it depends on the use of them and which ones you're using. It's a bit of a cop-out, I guess, isn't it? But again, they've passed their biocompatibility, so they're classed as safe. That's the first thing. If you can balance, because most antimicrobials are going to be cytotoxic. You generally measure cytotoxicity from a scale of 1 to 4. 1 is mild or no cytotoxicity, whereas 4 is severe. So they're all going to vary on that scale, of course. But going back to the surfactant approach, if that surfactant has been shown to boost the antimicrobial and suppress the cytotoxic effects of that antiseptic, there's no reason that because you're going to get residuals in there of the surfactants and antimicrobial. You're never going to wash it all out.
Right.
So again, that comes down to the clinician. But as I said, because it's past biocompatibility, it's classed as safe. And don't forget, with a lot of bone cements, they're putting antibiotics, particularly gentamicin, in these scenarios, aren't they?
Oh yeah.
So we know there's a lot of antimicrobials already being left within the wound. So I wouldn't consider it, in my personal opinion, a major issue, but it depends on how toxic that antiseptic is used in the first place.
So this has been very helpful. So I want to just move us for a few minutes on to treatment. So let's say I have a patient who's got clear infection, and I think that what we're seeing now is, typically in an orthopedic infection, because of this concern with biofilm, we've had to remove the implants. We've often been told that if that infection has set in and it's not clear exactly what the duration is, but standard of care is often that you have to go in there, clear everything out, put a spacer in, come back and do a second stage. There are some who recommend a one-stage procedure. But it's clearly very burdensome for patients. And in an ideal world, we would be able to eradicate the biofilm and retain the implants. So I wonder if you have any perspective on, the role of surfactants, the role of antimicrobials in treatment, and if we're going to see any advances so that might allow us to do more implant retention.
It's always a difficult one because, as I said, it goes back to this scenario of prevention, doesn't it? If preventing things is always a lot better from a management perspective. If the hardware has become contaminated with any microbe, unfortunately, that bug goes in a dormant state, and it could be years before an infection has occurred, and it probably is from the first time that surgery has taken place. It goes back to surfactants, as I said, has a role to play, as I said, with altering a surface, because you've got to bear in mind as well, anything that is put into the human body will become conditioned within milliseconds with anything it's been exposed to in the human body. So the bacteria itself aren't attaching onto the device itself, they're attaching onto the conditioning film that has been formed by the human body. So the minute you put, say, an intravascular catheter in, central venous catheter, that will become conditioned with a protein film. So that can be beneficial for adhesion, but it also could be detrimental. If you could put a surfactant on there to make that environment hostile again, to make it slippery, to prevent those bugs attaching, that would be more beneficial. And provided it's a surfactant that isn't cytotoxic and it has a role to play at supporting biological healing, then that could only be a benefit there. But as I said, in terms of infection, if infection has developed, you'll often find the culture negative. When you take a swab or take a sample from an infection of a patient where the orthopedic device is, it becomes culture negative. And that is generally because it's a biofilm. And swabs, for example, you're not going to recover bugs within a biofilm state. So you may swab an orthopedic device, but as I said, biofilms are very, very strongly attached onto a surface. You've got to apply a lot of pressure. So whenever you take samples, for example, from a wound, as a microbiologist, swabs, okay, but a lot of the time you'd want an aspirate or you'd want a biopsy sample to prove there's a biofilm in there. What you've also got to bear in mind, again, that the bacteria, if that they may be in the orthopedic device, or they may actually be formed within the tissue, because we get a lot of invasive biofilms. So it's a bit like when you're brushing your teeth. What we know is we can get endocarditis if you have problems with your heart valves, and that is generally the bugs from your teeth getting into your bloodstream and attaching onto the heart valves. And we know these bugs can be taken around the bloodstream to areas, for example, where there's been an incision or you've got a wound. Because we have this system, it's called Anakeresis. It's the old way of bugs get attracted to where there's inflammation within the body. And these bugs can move from different regions of the body and move to where there's more inflammation. That's why men, for example, with the prostatitis, a lot of the bugs have come from other areas of the body because they've moved around to where the inflammation is. So it goes back to prevention. To increase the longevity of orthopedic devices, it comes down to good surgical practices, and it's having enough armory there to prevent. If you can't prevent and there is an infection, again, that has to be cleared out with debridement, desloughing, washing with surfactants, washing with antiseptics, and ultimately you're cleaning that environment and making it hospitable for regrowth. And unfortunately, it's like indwelling catheters. If you have a biofilm in there, you have to remove it and replace. But
So
washing, cleaning.
I'm hearing you loud and clear that we need to figure out how best to prevent infections. I mean, these surfactants and antimicrobials may have a role in helping us debride a chronic infection and remove the biofilm. But the secret sauce here is utilizing these agents in the primary procedure, perhaps, and ensuring that we do everything we can to prevent biofilm formation, to get on top of these bugs, which are a lot more clever than we ever gave them credit for.
Well, they'll outlive us. It's one of these scenarios of they've been around a lot longer than us, but they started in a biofilm, you see, not within a planktonic state.
Well, Stephen, I think this has been the most fascinating conversation, and I know that I've learned a lot. I trust that our listeners have learned a lot. We've learned quite a bit about the complexity of bacteria, the complexity of biofilm, and I think we've learned some strategies to help us hopefully prevent and if necessary, treat infection when biofilm is present. So I want to thank Professor Stephen Percival for being with us today, and it's really been a great conversation. Thank you so much.
Thank you very much. A lovely conversation. Thank you.